Welcome to the Innovation Room, the space we explore the application of technology and AI in business, the practical and sometimes philosophical ideas shaping our future. Today we are delving into a very complex part of the healthcare system, the hospitals. There are very big questions to try to find a potential answer to. How can we navigate complexity of protecting patients' privacy and the need to access data fast in hospitals? The natural conflict of efficiency in AI-driven diagnostics and decision-making in hospitals with lack of or low human trust in those decisions. And most importantly, how does this technological evolution resonate with the human element at the core of what hospitals offer, the place we visit when we are in our most vulnerable state? We will discuss how AI, albeit slowly, is reshaping patient care, challenging conventional practices, and redefining the role of healthcare professionals. We not only go far in the future, but also we discuss the potential path from now to the next phase. I am Somayeh, CEO of Geeks. Please join me in the Innovation Room with two Chief Digital and Information Officers, Mark Thomas, CDIO of NHS Bedfordshire, Luton and Milton Keynes Integrated Care Board, and Barry Frostick, CDIO of Mid and South Essex Integrated Care Board. Hi, Mark and Barry. Thank you so much for joining me in the Innovation Room. Shall we start with a quick introduction by yourselves? Barry, you start.
Yeah, sure. So hi, so Barry Frostick. I am the Chief Digital and Information Officer working across Mid and South Essex Integrated Care System.
Yeah, hello everybody. I'm Mark Thomas. I'm the Chief Digital and Information Officer working across the Bedfordshire, Luton and Milton Keynes Integrated Care System.
Wonderful. If you say one thing about that would be the highlight of your, I'm sure, wonderful careers. What's the highlight? What's the biggest thing? If you want to describe, because you're in charge of hospital systems and technology. That's very exciting.
For me, it would be going back to when I built the first data warehouse and integrated a number of hospital systems together back in early 2000.
Wonderful. And Mark, what's your proudest moment?
There's big ones and little ones. The big one would be actually digitising the whole of a nursing service across a hospital with 11 sites and getting rid of paper. So actually allowing and freeing up the nurses' time and actually making the nurses digital, to which they actually liked.
When was that?
When we went live we completed the rollout in 2018. So we started in 2016 and had quite a phased, controlled, clinically led rollout and finished in 2018.
Yeah, wonderful. And we have a tradition in the Innovation Room, which is you've got to bring somebody with you, fiction or real, if you wanted to do innovation, dead or alive, who that person would be. Mark, you go first.
Well, yeah, that would be interesting, because what I'd have to do is let them fight it out. Because first of all, you want to bring in somebody like Steve Jobs just for that clear, true innovation, the advancement of what people don't know that they require yet. But I'd want to bring Barack Obama in to explain it to everybody.
Wonderful. Barry, who would you bring?
I'm jealous now of Mark's people, but I was going simply on J.R. Tolkien because to have that level of imagination, to write that level of detail in the books, I would love to bring him into the room.
Wonderful. So let's get into the future of hospitals with AI. Our regular listeners know that we follow a dare or die bullseye framework to explore the future of a sector with AI, where we look at how the expectations are changing, how what kind of constraint that sector has, what's the real problems that sector solves today, and what would that change basically with the advancements of AI. And then most importantly, at the core of the bullseye was the role of human in that sector and different businesses within the sector. So shall we start with patients and healthcare professionals and different stakeholders in the hospitals? today, what do they expect from the hospital, and how do you see their expectation has changed with the advancement of technology? And what's your prediction that their expectation is going to change with how AI is changing our life and how we interact with different businesses who are implementing AI into their business? How the hospitals are changing?
It's a huge question, uh, of course, but and the correct question. So you mentioned the migration or the changes that are coming places. So hospitals that deal with, obviously, with the emergency elements, which is unplanned entry, and also the elective of the planned element that's coming in. So what a resident, what you or I would want for is great care, and that starts off the unplanned stuff. It's just the genius, the little miracles that are delivered every day by the people. For the plan stuff is, I'll start off with. I won't go right to the end because obviously we've got Barry as well with put this. But to start off with is, if it's planned, you'd expect everybody to know what they need to know about you when you get there. So you have that confidence that everyone knows the information that is required there and then. You still will always be asked your name and address because they still need to uniquely identify you and all of that element.
Or does it, can it facial recognition me? That's a
Well,
question we don't need to get into, but
that's where we get to, but it is at the start. The question about what do you expect from where you were to where you are now, and it's about that information about the person presenting.
So I think, I mean, there's a few things, like Mark said, that's a huge question, which probably means you've got a whole kind of myriad of things fallen off of. But primarily, when I go to hospital, I expect to get great care. Number one, ignore everything else. I want great care. I want the best treatment and outcome, and I want people to treat me with compassion and respect. So ultimately, anyone as a patient who's coming into that hospital or that environment to be treated is vulnerable, and they need to be cared for and provided that best course of care. And for staff, anyone that works in the hospital, they want to be able to provide that. The whole reason a lot of people work within the NHS is because they are compassionate. They care for people. They want to help people. So they want to be able to do that in the best way possible. So I think there is a whole piece there which will remain true no matter what happens with technology. And that will something that you would want from a staff perspective, or from a patient, or from a family member for somebody that's being treated. I think the expectations, though, even if I look at my children now, they expect that knowledge is available at the click of a button. They would not expect to turn up and not have a primary care record shared with a patient within the acute sector. If I had a mental health condition, for that not to necessarily be available. So they would expect information about me as a patient for when I'm being treated by a professional to be at the hand of that profession. And I think our clinical workforce expect that as well now, and get frustrated that sometimes that's not always at hand. But I think there is a challenge with that, because there is so much information about a patient. It's then, how do you turn that into something which is useful at the point of time of care, depending on what the needs are? And that's one of the huge challenges that I, and I'm sure Mark's heard this as well, would hear from clinical staff saying, I haven't got time to click on 6 different systems to be able to try and find the one bit of information which is going to change how I care for the patient. So there is a real piece where I think the future will change, where we actually get that information presented straight up, and AI plays a really good role in being able to support that.
That's a really nice segue to, okay, how the expectation is going to change with where technology is going. And one of the angles that I always see is that going from a reactive um, healthcare to a proactive, like preventative. So I don't want to go to hospital when I do have cancer. I want to go to hospital to be prevented from getting cancer or that kind of stuff. So that I think it's we can't have it without AI and lots of data and be able to process data that we don't necessarily collect today, or it might be collected by third parties that are not available to hospitals. So say, for example, I've got my whatever wearables that has all sorts of information collected from the kind of behavior that I have that could be useful for the hospital to know. Whereas I might not even remember to share that. I might not even pay attention or think that's an important factor to share with them. So that's that part. But like on the operation of the hospital. So let's talk a little bit about the management of the hospitals and people who actually run the hospitals. What do they expect from the hospital, and how AI can change their expectations, do you think?
You've covered up some of the reactive, which we have to do, and as Barry said, they're very much about getting the right information in front of the person at the time, even if it's reactive, to the proactive. So if you're looking at the proactive element, it's actually getting the resident the care that they need in the most appropriate setting. So we can't go down clinic. I certainly can't go down any form of clinical pathway because I'm absolutely not clinical. But if you want, you need to think about it. Do you need to go to an outpatient appointment if it can be done through some other form of intervention? That frees up how the hospital's done. But then the learning that's been done, if you're using AI, I'll just think of something dermatology. If we can actually do a dermatology assessment in a more local setting, which is using AI to save a clinic session, outpatient clinic session, frees up clinical time to be doing something more proactively with somebody that absolutely needs that time. And as Barry correctly says, great care. That's what you're all looking for, and clinicians always do their damnedest to do great care. But if we give them more time for great care, you get great outcomes. So it's how we actually move that from a potential hospital management to say, how do we get the people that we need to see for the right reasons into the areas with the information for that, and how can we use technology such as AI, such as using dermatology? There's lots of different things. Just to say, how can I do that? How can I speed up the process for you as the individual? If you are then getting a positive result, i.e., you're actually fine. Thank you. We've opened the box. There's no surprises in it. You'd be relieved to hear. If you get that within a couple of days, that's better than having the anxiety of 3 weeks and then the trek to hospital and then waiting and then saying you're fine. So that does what the hospital administration might be looking for, because you're seeing appropriate people, but never lose sight of the resident.
It's really important. I think the point you're saying is very important because it's all about efficiency as well. And I think from a management point of view, you want the kind of right people in the hospital at the right time, as opposed to lots of other people that shouldn't be in the hospital, or they don't need to come at the time that they are visiting. So like making it very efficient and effective in terms of the people who need to actually visit. So what can be done outside the hospital? How do we make sure people come in when they need to come in, they stay for the exact time that they need to be there, as opposed to, inefficiently. Does that, Barry, maybe go to you, does that mean, do you see the hospital's physical structure will change as a result of technology advancement? Do we need to have the large hospitals that we have, or the way we organize them physically? Because we know how difficult it is to change. But is technology, do you see, is it going to push it to change?
I was going to pick. So I will answer that question in terms of what I see, but I think there is a whole here about which Mark was touching on about prevention sometimes, or trying to stop people coming into the hospital if it's not needed. So getting to it early, and I think actually if we looked forward 10 years time, 15 years time, AI will be much more powerful than what it is today. It will move from the piece of I'm going to ask you to do a little bit of code, and you can really simplify this nice process to more general intelligence. And it'll have that capability, I think, to be able to spot opportunities of disease, that personalised healthcare and that prevention agenda, which is what NHS England have been asking for a while now. And actually, if you think about Mark's role and my role in an integrated care system, a lot of that is about trying to sort out prevention and health inequalities and other aspects before you get to the door of the hospital. So I think there is a whole piece there about actually what are the capabilities that AI could introduce for personalised medicine, for being able to monitor and predict the need for planned interventions, um, which will shift the level of care and where care is provided. So all of those items Mark was talking about, that's where AI can become really powerful. Will it change the building? I think absolutely. I mean, that will take more than the 10 years time. We know how difficult it is to actually get infrastructure and buildings in place. But if you follow that through, the fabric of an acute hospital may well change from targeted, planned, known interventions at point in times, depending on that personalised care journey. It will be more focused around emergency situations for which you can't always predict. A car accident, falling off of a ladder, those kind of activities where you have to have that fast acute care provided to manage those unplanned environments. So you may well see the environment of the hospital changing to be much more planned on one side and then much more reactive for emergency situations.
It's an interesting point, because if we are talking about the offering of hospitals in the future, we might even see that the emergency stuff, which I totally agree, the unplanned emergency stuff, we never, like, AI can't help us. You could argue, yes, if you have autopilot, like auto driving, self-driving cars, we see less accidents. Sure, we see less accidents, but accidents will happen, and then we have to have emergency rooms to be able to care for those kind of patients. But would it be more like we would have a smaller emergency hospitals for unplanned things that needs immediate, intervention, and less of large hospitals, but those ones are more for planned stuff? And that's a massive challenge for UK alone. I'm not talking about the countries outside the UK, but that's a massive challenge for the UK to create that kind of. But also it could have a lot of benefit, because if we have larger hospitals, it means like all the healthcare providers that are specialized and they need to be in the same place, they can go. There are less traveling for them. They're more available in some hubs, and then the emergency stuff is more scattered, so people get to them faster.
I think you'll see a shift of what you need care for. So, if you plan forward to things, so less emergency situations, less accidents, granted. You're then able to do the preventative stuff. What you may well end up with is a more frail, elderly population, because you passed a number of points when somebody actually may have passed away within an acute hospital setting for repeated care, for which they could have mitigated if they'd have caught it earlier. So you'll end up potentially with an environment where you have a different cohort of patients, and then the question becomes, where's the best place to care for those? Is the best place to care for frail elderly people in a hospital? I'd argue probably not. Maybe in a community setting, closer to home, maybe closer to friends or family, or care homes. So actually, you will see a shift. How you can predict that, it's an interesting question.
Yeah, so some of the prevention there. So when you go into ED, as we contact, you're talking about the trauma access into ED, about the accidents. No matter what we do with clever AI, if someone's painting the gutters and they fall off, they're falling off a ladder, so they're still going to get there. But it's also the medical element that comes in. So you've got your trauma and you've got your medical elements. So this is where we come right back to the prevention. if we're doing, if we can pick on various medical things. Strokes is big. Stroke is a big thing. I'm going to lump heart attack, but you've got different forms of that, and the prevention, which prevents the medical presentation, and which was part of the key element in your ED. If you want to redesign the emergency department, which means you've got to have theatres, which means you've got to have some sort of ITU setting and behind it. So it is more than just purely the emergency department you see. It's everything that you've got there to the support. You don't always go from the emergency department to a ward. If it's a major trauma, you might go through surgery, you might go for a period, even planned with surgery, into ITU and maternity and all the paediatrics. It all sits in. So it's quite a large thing. So reducing medical admissions is part of your longer term, and that's about your predictive and using AI, not only just in prediction, but to help the individual through public health and population health lead fitter, better, healthier lives, so that you've got less risk of any form of heart attack or stroke, and tracking it and taking interventions, and then as we've mentioned earlier, empowering the person to be to just be a healthier person through. You mentioned wearables, about actually moving more, monitoring diet, all of the good things that the wearables can do for you as an individual to motivate you, because that's the other thing that we need to do, is not just track people. So then monitor, not we track monitor. We're not trying to have that over-protective society, but is to empower people to take control themselves, and that's the challenge you'd get from wearables, is telling you that you need to do something, set goals for individuals, and it reminds them, and it reminds them. So they set.
Sometimes a gentle warning would be good. That, like, if you're not, like, if you don't do this, if you carry on, say for example, I don't know, if you carry on even working out with the rate you're working out, with the age you are, and your other data I have on you, like this level of activity, you're going to have a problem. So you need to, for example, slow down or put time to recover. Otherwise, you're going to have a heart attack. Even like that kind of warning it's always tricky when it comes to health. And as technologists, we always have to deal with that challenge of not only what do you do with privacy, but also what do you do with the information you have that you can share with people when it comes to their health. If there is any prediction, because different people, and it comes to the constraint of the sector, if different people want to know different level of information, somebody might want to be very curious. Am I likely, with everything you know about me, am I likely to get cancer, and what can I do about it? And somebody else might be like, I don't want to know the percentage of the chances that I'm going to get. Like, I don't care, like, just tell me, like, the good information that would help me prevent it. I don't need to know that. So it's like different people with different cultures, with different personalities, would want to know different kind of information. And that's already, it's hard for healthcare professionals when they are dealing with people and telling them what they need to tell them. So I think that with the information growing and the predictions that AI would be able to make, then it becomes a bigger constraint, bigger challenge. Is there any other challenge or constraint that you see in the sector engaging with technology, more specifically with AI?
So just to look after somebody's health, it's far more than what I eat and what I exercise. The actual health element of it is quite a small part. There's a lot of the information that comes from within an ICS, within the full system, from our local authority partners, the environment. I mentioned public health right at the very start. So that's when you start to look at the whole social impact of an individual. Barry mentioned about making sure that we're targeting health inequalities, the people that don't engage for whatever reason, or are not engaged with for whatever reason. We need to give them the fairness of the opportunity, and that won't just come from a hospital interaction or a GP interaction. That'll come from the wider elements. So you've got to encompass the wider elements to help lift or remove health inequalities, and then to help share it. So the health benefit for me, for an individual, is wider than purely my access to GP, what I eat, and what I exercise. There's other wider things that we need to, and actually tailoring that brings in, or actually using that wider information enables you then to use AI, predictive analytics, effectively in the public health arena or population health, to focus where you need to put your efforts. If you put your efforts in correctly, we're talking about the hospital, then only the appropriate people go back to the hospital, because we've used intelligence to say where we should be putting our limited resources for the maximum effort.
Yeah, yeah. You're both very involved in the current setup, and you have been involved in improving it and implementing technology in the system. So what is the specific, maybe Barry, you jump in first, what is the specific challenges of UK hospitals when it comes to implementation of technology specifically, if you want to talk about AI more specifically?
So, I mean, there's always a few challenges. I mean, the NHS isn't awash with money. One thing. So there are financial constraints and challenges on the service and the system at the moment. However, I think if there's a strong, compelling case, those things can be worked through. It just needs to have a strong evidence base. So that's not going to stop items. The regulation and control that you would need around this is very stringent. So it's probably more stringent than the financial regulations, which are hard enough to get things agreed in, because actually the impact for which we have is not about losing £1,000 or £500. The impact is somebody's health. So the regulation that exists to be able to test this, to go through and get an evidence base behind it, is a real challenge. And if we think about AI and some of the conversations that we've had about it monitoring information and giving advice out, all of a sudden that starts to become a medical device, and then go into medical device regulation, which takes a long period of time. So I would say that, currently regulation will be a challenge, and that's not to say it wouldn't be tackled, but you need to work it through and have a strong evidence case to be able to say this is now safe to use. And there is always that wariness, I think, that some people have of, do I really trust what the computer's telling me? And a lot of that is born off of the data for which it derives a decision from. If you've got bad data, it's going to give you bad advice. And we've seen that evidenced multiple times around the use of AI to say, find me a case where this happened. So there is a real risk that poor data could lead to poor advice from those machines. And I guess that's the type of thing that the regulation and the testing would need to get strong assurances on before it was mainstreamed within the NHS.
Yeah, can I jump in there quickly before we go to Mark? I think that's very true, but for a very high risk decisions to be made, there are always like a range of implementation of technology use cases. So if we talk about, for example, using AI to take notes from a consultation and create actions and things like that, then that would be so much more less risk than asking AI to actually do a diagnostics or prescribe something. So that's easier to be implemented compared to some of the more high risk ones. But definitely that is a big thing. Anything, and very, very amusing, I always find, we trust the human so much easier, and humans make so many mistakes. Like bad data to a human doctor is going to result in bad decision. If they don't have the right data, they're going to make a mistake. If they're not trained well, they might make a mistake. And we don't question those as harsh as we would question technology when it comes to technology. And obviously I'm a technologist, I'm more more keen with technology and kinder to technology than I am to the humans. But going back to Mark, what do you think are the biggest constraints in implementing AI and technology to hospitals?
So if just simple, just to bring on that, if electronic prescribing and medicines administration, if it gets something wrong, it's a major incident because you're regulating it so much, it's got to be right every time because you're taking out that human element. So the big shift is from the passive element where we use AI clinically, i.e. a second read. That is fantastic. What a superb safety net. That is just that should be everywhere. Any diagnostic should have a second read, and that gives you the data to say you can run then in parallel the future to say if that was presented in a completely different way, would the AI have made exactly the same decision? And where it's asked for a second read, has it learned that that was? I'm thinking histopathology or anything like this where you've got something massive, the potential for the masses of spotting a single cancerous cell on a load of slides, the slices. It's genuinely going to speed it up. Now, will you have that as a primary read, then going to a professional to do a second one? Or would you have it as a second read, which is we currently have the option to, which is it's gone through everything and it'll only look at the ones that have not been followed up or said that you do, and it said you might want to have a look at this one. And it's that swing, and that swing comes from confidence, and the confidence comes from how much data and how many times has it got it correct.
Yeah. And I think there is a cultural element, there is education, and how do we bring the public along with us in any sort of technology implementation, which unfortunately most of the mainstream media, they don't try to educate the public. They try to warn the public and create like excitement about like, oh, this has gone very wrong. And it's not about like, how do we bring the public along the way, because it's kind of like a evolution of our healthcare and evolution of our hospitals. So there is going to be a lot of step changes that happens, and the public need to be educated, and they need to understand why these changes are happening and how that would impact them, and how can they validate, and if they have a question, what do they do? That kind of stuff doesn't happen enough, I think.
So that's making the NHS website, just as an example, which is a good source of information, and there's a lot of processing on there about what are my symptoms. Look at it. This ring 111, GP appointment 999. It'll take you through. It's a trusted source. So if you're going to use informed decision making, it has to come from a trusted source. I would say, not Facebook. Nothing wrong with Facebook. Fantastic social media, brilliant. But you don't want to do your medical diagnosis on there. So what you need to have is that trusted source. If you talk about education of people, it's about making sure information is correct, evidence-based, and it's from a trusted source, so that you can say this has been validated through this route, and that gives people the confidence to say, this is whatever you have.
Could you see, any of you, could you see, for example, the future hospitals looking like, and don't judge me for saying that, but just looking like a Burger King, that you go in and there are self-service kiosks that you can go and order there, and there is a human behind the counter that you can go and order there, and you still see humans doing some work there, but there is the option of the more self-services stuff that you can interact with technology to get. Is that something that you could ever see hospitals moving towards?
We've been parking electronically for many years, just so you can go in and register. I'm just thinking of just taking that through. You're going to go through registration. That's available now, so you can go.
Well, I haven't seen that. And like anywhere I have gone, and that drives me mad, because I'm like, I can, instead of me sitting there, or you even, like, don't think about me as a patient and my time being valuable. your time on the other side, your time is valuable. Why are you spending time taking my name and address and making me register? I can do, if you give me an iPad or even give me a URL as I'm sitting there, give me a QR code and I just put my information there and you have it on your system. That's like a, really annoying. I haven't seen it anywhere, and I live in, if I want to embarrass my NHS hospitals around me, I live in south east of London, so sorry, kind of area, Sutton, that I've been in those kind of hospitals, and I've never seen emergency or even the private hospitals I have gone to. They all make you fill in paper.
So, I mean, that's interesting. I mean, I was going to say, I'm glad you didn't say you was in a northwest London hospital where I did implement self-service
I
check-in.
wouldn't have said that. I wouldn't put you on the hot seat.
And so, so, so that technology, that ability to use a kiosk, as we used to call them when I implemented them at the hospital quite a few years ago now, exists. And we were at the time, I'm probably talking about 6 or 7 years ago, using QR codes on a mobile phone for those people that had it. And we still had the backup of a receptionist there for those that couldn't use it. And we found out places like, if you're looking at ophthalmology, it's really hard for people to be putting on the screen because some of the reasons they're going to hospital is because their vision's so poor. Or those with arthritis in their hands would complain that pressing the screens was hurting. So there are cohorts that were always there with receptions, but I guess that stuff's there. The bit that would be more interesting for me is whether or not patients are almost able to navigate the healthcare system based on them understanding what the conditions are that they need to see before rocking up to see a specialist, to then have that specialist say, yes, you do need to see me for some treatment. To almost cut out some of the activity that happens that might not need to be there. So I know when I've gone to hospital, I would turn up, there would be a consultation and a conversation. There would then be a discussion that I'd need to come back for some level of treatment. And actually, if that conversation and consultation could happen more virtually, could happen automatically based on conditions that are fired across and trigger points, then you're saving capacity in the NHS. You're saving time for that member of staff, that member of public, me as a patient, and you're increasing the time that I could get potentially seen and treated. And quite often, the quicker you are treated, the better your outcome will be. So for the NHS, much more efficient. And for me, if there was something we could focus AI on within the healthcare setting, it would be how do we improve the speed from initial concern to treatment?
Okay,
That would be
really,
really powerful.
I think that's really, really important. So, given that, so if you're, I hear most of the stuff you're talking about is how do we make it more efficient for everybody, more effective and efficient for everybody, and that's the way AI can make a big impact. We know it's good to make things more efficient and more effective, and technology as a whole. So if that's the direction we are moving towards, what's the role of human in the hospital? So if I say, I predict in 10 years time, 20 years time, technology can do everything that individual humans in the hospital do, machines and robots and all sorts of technology, IoT sensors, everybody can do whatever. So you just move from robot to robot, or they come to you and move from you and then take everything that they need. What is it, the role of him? Why do we want humans in the hospitals, or do we want humans in the hospitals? I have a view, but I let you guys share.
Other than being fearful of being like a car on a conveyor belt in a BMW factory getting fixed and put together by robotic arms, that would worry me. I think there is a significant role for humans to play, for a human touch, for want of a better word, on things. As going back full circle, when you're ill, you are really vulnerable. You're at your weakest kind of moments, and actually that's when you need the support of others, whether that's family, whether that's friends, whether that's a nurse by your bedside telling you it's going to be fine. You may be able to get robots to do that, but no pun, it will feel quite artificial.
So we've got it now. We do have the intelligent bandages and things that you put on people now, and the compression things that monitor. There's absolutely stuff that we can do with that. Take that out of the hospital, so that your monitoring and your interventions come in. Use technology to provide support in the home. I think I think the word, Barry, is the human touch, isn't it? I think as human beings, you expect the human touch. I like your point about the vulnerability, the way you bring that out, because you are, and we're a long way off a compassionate robot, I think. But I think the intelligence is still on the AI element is to keep you well, keep you healthy, support you and motivate you in doing this, provide the care and compassion, provide the care or the alert outside of the hospital space, so that someone can take an intervention, so that AI learns how Mark in older years wanders around my house, listens to everything. You don't have pressure mats and all the rest of it, and then just knows that actually it's really clever stuff that I'm not walking as well as I did, so I'm likely to have a fall. So let's not wait for the fall. Let's put some interventions. That'll be fantastic, because that's still supporting me living an independent life. Um, use the stuff going forward, but I don't know if we're ready. Maybe it'll be a generational thing before we have
It
that
could be.
AI
There is
element.
that element. I think we can't ignore the generational change and what comes with it. When I look at the young, I don't know, 5-year-olds and how they interact with technology, I feel old. And I feel, oh, I'm from a very different generation, let alone, like, you feel the generational change when people have grown up with technology and they have been born with technology. But I completely agree with both of you that we do. I think we always need humans in hospitals and in healthcare, just because we are vulnerable. Even if you're not sick, discussing our health makes us takes us to a very vulnerable state. And even if we create a robot and AI and a form of technology that can empathize and can create, like, be that loving whatever person, because they don't experience what we are experiencing, we never believe them. So they can create that artificial sense of, oh, I understand you, but deep down, they don't understand you. They don't feel the pain. They don't feel the anxiety of waiting to hear what's going on with me. And I think that's the role that is really, really important. And you need to be able to trust the person who does that to you. So when I am sick, yes, if my family or friends are telling me, oh, you're going to be okay, it has a little impact. But if a doctor tells me, a specialist tells me, no, you're going to be okay, we look after you, that has a massively different impact, because I would go to the place that he knows or she knows what is the situation. If they say it's likely to be okay, then I can believe them a lot more than, the. So I think that for that reason, like, that human touch is going to be always important. But isn't it wonderful if we bring more technology so the people in the hospitals can actually do that job, as opposed to running around trying to do the basics, trying to get your records or the data, and trying to find the right, I don't know, medicine from the right cabinet, or that kind of stuff.
So the AI will bring into the personalised. You mentioned medicines. We've had it a few times. It's the personalised care and targeted medicines. That's
Yeah,
where
yeah, yeah, yeah. That's a
that's
whole
where it
different.
comes from. If you look at warfarin, if we can absolutely target warfarin, it's not a continual assessment of whether you're high or whether you're low. It's this is what, and you can do that for all the jobs. What is the amount you need, the process for the duration, and that's based on that will be going down into genomics, which you'll need an AI to analyze, just because of the vastness and the complexity of it. So I think in medicines management, we're just at the the starting point of the benefits. And again, we've got to go through the safeties. We mentioned the safety and the sign off it, because you can't automatically, you've got to be really safe to make sure if you're automatically suggesting doses of medicines that impact people's physiological well-being, that it has to be right every time, which is why you need to have the large numbers, the test, and running in parallel to say, is this running? What decision would it have made, and what would the outcome have been?
Thank you for joining me, and lovely to have you in the podcast.
You're welcome. Thank you.
Cheers.